last two questions. So I want to take a minute and share the screen and talk about those last two questions. Most of the time, people were giving me correct information, but it wasn't answering what I was asking. The other thing I saw was there was a switching of what I did talk about, since it was only verbal, and what I was actually looking for the first of the two questions in the second one. So if you've got your blood pressure, or not your blood pressure, your let's take a look at those labs.
Yeah.
I'm going to have to silence you guys.
You just have to put that question and put it. Yeah, I'll do that. Do you want to look at them real quick?
Okay. So I have muted all you guys. If you want to say something, you can turn it off that you want to talk with the class about. So one thing I want to be abundantly clear about is if you are seeing a change in heart rate, then you're seeing something that is influencing the autorhythmic, in particular the SA node, unless it's not functioning, and then it could be the AV node or even the bundles of His. So this is autorhythmic. So I think I buried my handout. I don't remember the exact way I worded it, but it said, what is the effect of exercise on heart rate? And many of you would discuss appropriate information, but what I'm really looking for is a mechanism. How does, or why does, I think it said why does, not why for, what is the usefulness of it? I meant why, how, give me a mechanism. So I didn't take points off if you really gave me a lot of good stuff, or at least not much points off. But if it was relevant but not really asked, or you got confused. So when you see a change in heart rate, you're talking about changes in the autorhythmic. They are responsible for the heart rate. So the mechanism that I went through verbally without talking about in particular is if you then increase sympathetic onto these guys and release norepinephrine, epinephrine, then what you're going to be doing is you're going to be affecting the funny channels. So these guys' funny channels, remember, were chemically gated as well as opening with hyperpolarization. So what they allow in is sodium. So the increase in that will increase the rate at which sodium enters, not calcium. I had a lot of people talking about calcium. Calcium comes and becomes involved when you reach threshold. But the whole idea is if you increase sodium's rate, that leads to an increased slope of the pacemaker. Not the action potential, but the pacemaker potential. When you increase that slope, you reach threshold for the calcium, the fast voltage gated calcium faster, and you have a higher heart rate. That's what I was looking for. So if you didn't even bring calcium up here, that would be fine, only because nothing about it is changing. It's just that threshold is being reached faster by allowing sodium to come in through the funny channels at a faster rate, increasing the slope. So this is the first of the two questions. I should have numbered them so I could refer to them, but I didn't in the handout. These are the last questions at the very end. The second one was meant to focus on the effects of sympathetic on the interval. Now remember, typically we talked about the responsibility of sympathetic on the contractile fibers is to cause greater amounts of calcium in order to cause a stronger contraction. And that's all true, but that's not what I was asking about, because I was asking about intervals. In particular, it was all the intervals. I didn't even say which intervals. I said, why would they get faster with exercise? So intervals are the time it takes between the SA node firing to the AV node firing, or AV to the end of the QRS. All of you're seeing in the intervals, though, are you're really seeing changes in the cardiac contractile fibers rate of depolarization. Right? Because you can't see the autorhythmic in any way except by the heart rate. You imply that they fired, but you really can't see it in an electrocardiogram. So because this is an electrocardiogram, the only thing you can really look at are changes in depolarization rate of the cardiac contractile. So how does it change it? Well, if you have sympathetic, that increases calcium entry via chemical gates. So let's pretend we are a cardiac contractile, and normally we go down to -80, right? And then we cause threshold to be reached. So you get your action potential. Here's your action potential. There's threshold, say at -55. And the slope of this looks really steep because of the timing. This is hundreds of milliseconds. But if you drew it out, the reason you're getting to threshold is because you are having positively charged ions, we're not saying which ones, coming through gap junctions. But now visualize a world where you already have some positive ions in there, extra ones. So now you're going to add, maybe I'll change the color, you're going to add some calcium into there. Calcium is a positive ion. So if you open those chemical gates, and it's going to make this reach threshold faster, and therefore you're going to shorten the interval because you're going to get to threshold even faster than you would if you just had the gap junctions doing it. Now, that's not just one fiber doing it, it's all the fibers doing it. You add that up and the intervals get shorter. Not lots and lots shorter, but they do get shorter. And you could argue that the autorhythmic are driving the gap junctions a little faster, but you can't see that on a electrocardiogram. What you're seeing are the cardiac contractile being driven to threshold faster. So autorhythmic, they control heart rate. When we're looking at interval, we're looking at one beat. So you can't be analyzing heart rate with intervals. You can only be analyzing what's happening to the cardiac contractile fibers electrically. Okay, so I spent a little bit of time on that because it was a fairly common mistake in the handout. Are there any questions? Let me go to chat on that in case there are questions. So I did try to explain this at times, but sometimes I just, it was pretty short in your comments. If you look at your assignment and you click on the grade, it will show you comments I made in the speed grader that Canvas has. So if you want to see what your particular comments are. So I took slight amount off, half off or something if it was the few people who were late. Half point, not half of the grade. And then it depended on kind of how wrong you are, if there are other things wrong earlier as to what I took off. So you can always ask me what my rubric was. Okay, so I am going to stop sharing that, and we're going to move into blood pressure. And I do want to spend a few minutes on this because I want to orient you to where you're going to go. I will have there's one other caveat I want to say, which is I know you might be really overwhelmed with all those blood vessels, learning them and all those pictures, and you're doing that on your own time. But really, this is the last very busy lab that we're going to have before the lab test. And we do have that one whole review one too. So you do have time in lab also to work on that if you're feeling time pressure. It's just this lab is going to be pretty full. So you can time manage that. Let me share the screen with you, but this time I've got to open it up. What I want to share is where is it? Is the study guide for the lab practical or lab test. Oops, I went to the wrong thing, sorry. So used to going to my tablet, I didn't click on the right thing. Okay, so here is that study guide. Let me see if I dragged it off to the side, so let me drag it more into the middle here. So I am following along on, nope, in my lab manual, I think it's 30, did I put it down here? Exercise 33. And it starts with some theoretical discussion. Now, the newest version or the newer editions of the lab manual often put some of the theory in with these little activity boxes. So don't skip those, even though you're not able in person to do the activities. Make sure you read them because some of them have things about how you use a sphygmometer, how you use a stethoscope that I do want you to understand, even though you don't get a chance to use it. So one of the early things it brings up are things called pulse points. So these are areas on the body that you can easily feel an arterial pulse. They're good to know because obviously maybe there's sometimes that you, because of what a patient's condition is, that you can't take a radial pulse. Maybe their arm's broken or something. You can't take the radial pulse there because that would hurt them. So it's good to know that for those reasons. Also, you might want to learn how to take a brachial pulse, and we'll talk about how to do that because in order to set up the sphygmometer properly, you have to be able to palpate or feel for this brachial pulse. So I do ask you to learn these. Now, the good news is every single one of these is on your list of the blood vessels. You got to learn anyways. So once you know where the dorsal pedis is, that's the top of the foot from its name, or the posterior tibial, then you kind of know where a likely place is to feel the pulse of that, because you clearly can't feel it in areas where you have a lot of soft tissue, like the calf muscles here would interfere with you being able to push deep enough in order to feel those pulses. So learn these pulse points, and I suppose I could use a torso model or something, but I may just use a picture if I test you on that. Now, the other picture, and I believe it's the next one, and you have to spend some time on this one. This is in one of those little boxes in your lab manual exercise, and it talks about where on the chest you would feel for, or you would listen with a stethoscope for particular valve closure sounds. So you already know that when the AV valves close, they make this sound which we're characterizing as a lub sound. And when you, let me actually also have this going on here. I'll go back and forth. When you are listening for the semilunar valves, we called that sound dup. So on the chest wall, and obviously we can't even do this in person because it's a very personal place to be palpating people or listening with a stethoscope, but you probably have had a doctor do this. You can hear the aortic semilunar and the pulmonary semilunar on the right and left side of the sternum. So the sternum bone resides here, and you're at the second intercostal space. So this is rib 1 and rib 2. You're listening around that second intercostal space. That is the way I will describe a problem if I give it to you, is you are listening to this spot. This is what you are hearing. Now, of course, that is where you best hear these particular valves. You're going to hear lub-dub wherever you listen with a stethoscope, but you're going to hear that valve, if there's a problem with it, best if you listen in this location. So the tricuspid, not surprisingly, is on the right side, and it's in the fifth intercostal, and the bicuspid is on the left side. It's on the fifth intercostal. So the easiest way just to remember these is 5 or fifth rib down for the 2 AV valves, and the second rib down for the 2 semilunar, and then the right side makes sense for the tricuspid and the left for the bicuspid. Unfortunately, left and right is kind of reversed as far as the sides of the heart, but you hear the sounds of the aortic on the right side and the sounds of the pulmonary semilunar on the left. So what are you going to be doing if you were in person is using a stethoscope. Now, Kevin goes through in the video a little bit about the proper use of a stethoscope. He brings up some of the key points. So when you put the stethoscope in your ears, you've got to make sure that the earpieces are pointed towards your nose at an angle, because your external auditory meatus goes at an angle. If you just have them straight at each other, they'll push against the soft tissue of your outer ear and ear canal, and you won't hear very well. So that's one thing. And then, as he mentions, you don't want to be touching or having a lot of things touch the tubing, because these sounds are fairly faint, and any rubbing sound will interfere with them. You hold the head of the stethoscope so that you're not touching what's called the drum, the part that is picking up the sound. Some stethoscopes have 2 sides, a drum on each side, so you want to make sure you're not hearing that. And then you're going to be listening for that lub-dub. So what I'm going to be asking you to do, besides understanding that if I'm listening here and I'm hearing a dup, I'm hearing the aortic semilunar, and over here I'm hearing the lub from the tricuspid AV valve, is to diagnose murmurs. So I believe that, that I don't have anything in the study guide about them, so you'll probably want to take notes. The book does talk about murmurs, and I do give you sort of an example of one in the handout for you to work on. So I'm going to stop sharing this for the moment and start sharing my iPad. Now, let's not at this point worry about which particular intercostal space that we're hearing this at. Let's just take a look at a variety of murmurs that can happen. There's a much more of a big category of murmurs than we have, so we're just going to simplify this a lot and talk about 2 types. And one type is a leaky valve, and that is called incompetent. If somebody isn't doing their job well, then the valve is called an incompetent valve. It's not doing its job. Well, what its job is to prevent backward leakage of blood. If you're a semilunar, the blood would be leaking back into the ventricle. If you're an AV valve, it would be leaking back into the atria from the ventricle. And we're going to use a sound swish for that little leak. Now, the leak occurs when the valve is closed. So what you have to do is understand the cardiac cycle enough to know when the valves are closed. So you need to correlate the heart sounds. So this occurs, maybe I should do an arrow, occurs when the valve is closed in the cardiac cycle. So that doesn't mean you have to tell me the name or anything of that phase of the cycle, but you have to think about the cycle and say, if I'm hearing the sound lub, something like this, swish, dub. When I am right here in the cardiac cycle, which of the two types of valves are closed? The AV or the semilunar? Hopefully everybody who can, put it in chat, whether it's the AV or semilunar that's closed. So I'm going to write it in chat so you'll tell me. Tell me if E or somebody give me an answer. Okay. Yay, it's looking like everyone so far is giving me the right answer. Fantastic. So now you know, since it's clearly an AV valve, how do we know that? Well, we heard lub. Lub is telling you this is closed. We haven't heard dub yet. So that's telling you semilunars are open. A incompetent valve is a problem with the closed valve, whichever it is. So if it was a semilunar, you would hear the switch. Whoops, what happened? Oops, here it is. So this is an AV problem because that one is closed. If I were to hear the swish here, or don't, forget this is a cycle. It could be a swish over here. The ones in the parentheses are telling you that these are semilunar valves that are leaking. You okay? So then all you need to add to that is which intercostal space. So if it's an AV valve problem and I tell you hear that and you're hearing this at the right fifth intercostal, then it's the tricuspid. So I don't want to switch back screens again, that'll take a bit, but if you look on the right side, the AV valve at the fifth intercostal, that's the tricuspid valve. That's where I'm hearing that swish sound best. Then I know I've got a problem with the tricuspid. Okay, so what is the other problem we can have with valves that we're going to deal with at least? And the other one is called stenosis. Whenever a opening is narrower than it ought to be, that is the term for stenosis. So this is a problem with not being fully open when it should be. It's narrowed. Now, because it's narrowed, it's going to make a high-pitched sound, and that's what we're going to call screech. I think I spelled it like that. Screech. A very high-pitched sound. Just like if you were blowing in a flute, the tinier openings make a higher pitched sound. This is adding this high-pitched sound. When blood is trying to go through, it's unable, just like when air is trying to go through the little opening in your flute. So that's the screech sound. So let's do the same thing with lub. Screech. If I spelled that right. Dub. So now you have to ask who is open and who's open that can be causing the problem. So why don't you again answer if it's an AV or a semilunar that's opened at this point? Great. I think you guys got this. That's great. All right, so now you could hear lub, screech, dub. You know this guy's open, the semilunar is open because it has not yet closed. I'm going to get rid of the chat so I can point at this. It's not yet closed. You haven't heard dub. You know this guy is closed. So once again, the screech could appear on each side of these, yeah? And then I could ask, okay, it's in the left second intercostal space, and then you'll tell me it's the pulmonary semilunar. That is the problem. All right, some people struggle with this. Please practice a few of these, rearrange them, work with each other if you'd like in a breakout room to try these out so that you make sure you can answer those kinds of problems. All right, let's go back to the study guide because we're going to start the blood pressure stuff. So I have a picture here of how to feel for the brachial artery. And what you're trying to do is feel for your biceps. It's a big muscle, and your brachialis is under it, so they're both fairly big muscles. And you're trying to feel on the inner part of your upper arm, just above the elbow, for as much as you can press down an indentation right next to that bicep near its insertion at the right at the point of the elbow here, right in the antecubital area here. So you can try that on your own, but that's what you're feeling for. Now, what you're going to be doing in a step with the sphygmometer is feeling for that pulse. And you'll see what Kevin did is he put a cardio microphone to replace what a physician would do if they were doing it, or a nurse using a manual sphygmometer or blood pressure cuff, where they'd put the stethoscope in there and they'd be listening. Now, what they're listening for, and I probably mispronounce it, but the Kortikoff sounds are the sounds that blood makes when it starts to re-enter a collapsed vessel. So you've all had your blood pressure taken, I'm sure, and they put a cuff around here, blow it up so that blood, this is a fairly big artery, blood flowing through here is occluded. You don't have anything at all going through. Whether you're in systole or diastole, nothing is going through. And then you gradually release the pressure until when the blood is at systole and the pressure is highest, it manages to just squirt through here. So you have a very stenotic vessel. It's really closed down. So you hear this higher pitch sound, which is the first sound of Kortikoff, and that is picked up by the cardio microphone. So every time the heart is in systole, a little blood squirts through, but when it's in diastole, it's still collapsed down. So you'll see a little pulse for each systolic pressure, and then nothing, and then a pulse which is the pulse is the little sound of the blood squirting through. Once you decrease pressure enough that it's almost like, it's like nothing is there anymore. The artery is back to being fully opened, but it's the very first time you hear no sound. That means you are diastolic pressure. So you'll see on the cardio microphone the little pulse that is representing the screech sound that blood makes as it's trying to get through. Disappear during systole, that means you are at diastolic pressure. So understand how to use the sphygmometer to do that. Also, you should be able to make calculations once systolic pressure and diastolic pressure are measured to calculate blood pulse pressure and mean arterial pressure. And I've talked about that in lecture already. Now, why using the brachial artery? I explain this in the handout, but part of it is that it is very convenient. But another part is that gravity has an effect on the heart, and when you're seated, your heart and your brachial artery are about the same level. So the effects of gravity are not as obvious. You'll see in his exercise, if you haven't done it yet, that we try and use changes in his arm position to see how gravity affects the arterial pressure at the brachial artery. So normally when you have your blood pressure taken, you probably know this from having had it done, you want to be having your arm supported so it's not hanging down, and you want to not be using it. You can't be contracting it or something. So it's relaxed, and you want your feet flat on the floor so that there's no other activity or change in blood flow because you're compressing some other artery. And they usually take it here also because it's convenient. You don't have to get undressed, and you can put a blood pressure cuff on. Now, in the little mastering, they also compare blood pressure at the brachial artery to blood pressure at the, if I go up to the higher one again, at the radial artery. So blood is flowed through what are decreasing diameter arteries to go from the brachial to the radial artery. If your arm is supported and they're all both at the same level, then you can see that you see a diminishing of the systolic pressure. So if you took blood pressure at different locations, you would get somewhat different values because you now know that resistance occurs as the blood flows, mean arterial pressure drops. So it is our kind of convention to take it at the brachial artery and to use that blood pressure. It's not that you always, everywhere in your body, have 120/80 for a blood pressure. So they do look at that in the mastering. We're not going to go over that here, but I want you to do that on your own. We're going to use Kevin's. And that's described here. So they're actually using, I guess, your ankle, not your radial. And they're not using a microphone. They're using an ultrasound device to pick up the sounds or the movement of blood as it first enters. So they compare the brachial to the popliteal, the pressure in your ankle artery. And I thought it was radial, but I forgot. So using the ultrasound device, you can pick up the sound of Korkhoff is basically a Doppler sound as blood moves through the vessel. So this, you can read about this on your own. It can be used clinically. If we didn't have Kevin's, I would have spent more time on this, but I definitely think it's worth reading and watching. It's a pretty short little video. Okay, so I wanted to talk about some of the reasons why you can have higher than normal blood pressure. This has been integrated into this formula here. So they're using this formula where you have your systolic at your ankle and your systolic at your arm to look at reasons why you might have differences from normal. So here they're giving you these values. If it was fairly similar, or it was a little bit, the ratio up here was a little bit higher at the ankle than the brachial, then that's fine. Acceptable would be here. And if it starts dropping, then you're potentially seeing occlusion or partial occlusion of the large arteries, which arteriosclerosis can cause. So why you would get higher values when you get hardening is because the vessel itself is not able to accept the blood as easily. So again, go through this. This is all in the mastering, and it was kind of my backup plan. For your interest's sake, as much as anything, I probably won't do a lot of testing on this at all. But what I do want you to consider is some of the reasons why arteriosclerosis or calcification might raise your systolic pressure generally. So remember that the blood vessels are elastic, and in order to accept that systolic pressure, they have to be able to stretch. So if they're not able to stretch because there's calcification or there's plaque formation, in the lining of the vessel on those endothelia and the tunica intima, they're not able to stretch as well, then you still have to get the same amount of blood through, but resistance to getting that blood has gone up. So using our formula where delta P over the total peripheral resistance, you've raised that total peripheral resistance that we talked about today. So as soon as TPR goes up, in order to keep cardiac output the same, what you have to do is increase delta P. The only way to increase delta P is to ask the heart to contract harder chronically. So this is why when someone has high blood pressure, what they have to do, due to something like calcification or arteriosclerosis plaque, fat formations that are usually become calcified in their vessels, is their heart is working chronically harder all the time. And so eventually, it's difficult to get blood to circulate well, and you can have other problems, which we'll talk about. For example, if you have a plaque, you not only can disturb the elasticity of the vessel, but you can cause blood to flow more turbulently. Laminar flow decreases. So think of having I think in my slides, I use a creek bed, and you suddenly throw some rocks into it. If it was flowing laminar, the only friction would have been along the edges of the creek, and the middle water would go fastest. If you throw there, now some of that middle water is going and making whirlpools, flowing backwards, and that can cause greater resistance to flow, even without having the elasticity be changed. So when you have these fat deposits in arteriosclerosis, you're causing turbulence in the flow, you're increasing resistance, blood pressure has to go up to meet that. Hopefully this is making
Professor, we can't hear you, I think, even though you're not muted.
or Canvas. It's not my internet, I don't think. Okay, so did I get as far as the turbulence and resistance going up?
I don't think so. Did you?
Oh. I heard a little bit of it, and then
I think a little bit, yeah.
Where you paused was where you threw the rock into the middle of the river.
Oh, okay. All right, so maybe what I'll do, just hopefully we'll I won't lose you again. Otherwise, you're more than welcome to come to the later lab. Hopefully things will be worked out by then. Oops. Hold on. Okay, now we'll do that. Maybe a picture instead of my arms moving will help. So let's say your vessel looks like that normally, and you have friction along the edges and laminar flow in the middle. And then I suddenly put a big piece of plaque on the edge. This is usually, cholesterol, fat buildup. And what happens is then the blood as it's flowing, there's not only more friction along here, but you end up with turbulent flow, kind of like a whirlpool in a river. And that was the analogy I used on the slides, putting rocks in a river. So that now blood is not only flowing, just having technical difficulties here. Now blood is flowing freely and only in a small part of the middle and turbulently along the edges, because you don't typically have, one plaque deposit. You're going to have lots of plaque deposits in a particular artery. This is going to cause a great increase in resistance. When you have total peripheral resistance go up, the only way you can keep cardiac output the same is to increase delta P. And the only way to increase delta P is for the heart to contract harder. So even before you have, say, calcification of a blood vessel, if you're just having these fatty deposits in them, you get more turbulent flow. So this is turbulence. When you have turbulence, you're not just getting greater friction by going around something that's poking in. Each time the blood goes in the circular pattern, it's causing friction to occur. Now, shortly, we'll talk about blood clotting. It also will, as you'll see, tend to cause you to spontaneously clot. And that can be life-threatening for somebody who has arteriosclerosis. So we'll come back to that part later. Okay, I'm going to stop sharing that and go back to our, if it's still open, or did I close that in my struggles to get back on? I think I closed it. Lab test 1. I can't see it with you guys here. Here it is, the study guide. Okay, so desktop. Maybe I have to stop sharing. Are you seeing the study guide again? Just somebody just shout out yes, unless I...
Yes, we can.
Yeah, great.
Yes.
All right, I'm going to get over to where we're in blood pressure. Okay. All right, past that. And finally, we'll get to, all right, so we talked about high blood pressure, and you should also consider some of the signs and symptoms of low blood pressure. So I built into the study guide a table here talking about the stages of shock. So shock is when you have low blood pressure. Now, there's a variety of reasons that you could have low blood pressure. And the ones we've talked about are like low blood volume. If you don't have enough blood volume, it's hard to have enough preload to cause you to have good systolic pressure. But there are other reasons. Another reason could be heart failure. If the heart becomes weak, like any muscle that becomes weak, it can't contract as hard. This is called cardiogenic shock. I don't think I put the reasons down, did I? Well, maybe I did later. cardiogenic shock. You could also have low blood pressure, not because you actually lost whole blood, but you lost the water portion of the blood, some of the portion of the plasma, particularly the water and whatever is dissolved in it. Now that could happen because you're dehydrated. So you're not taking enough water in, you've lost too much of the water part of your tissues are not able to replenish the blood enough and your blood volume drops. So not only are your tissues deprived of fluid, but also the blood could be low in volume. It would also be more viscous. So all of that would tend to make it harder for you to keep your cardio output up to normal levels. Other reasons might be anaphylaxis, which means that you have such a strong allergic reaction that blood leaks out due to systemic inflammation. So lots of reasons. Regardless of the underlying cause, they've divided it up into various stages. Now, what I'd like you to do with these is to try and relate what you know about what happens when cardiac output is low to how your body's trying to compensate. So for example, in stage 1, you see a drop in blood pressure, but that drop in blood pressure can be compensated by vasoconstriction. So even though this is somebody who's normally compensating by doing vasoconstriction to raise their venous return back up, they will show potentially even a normal heart rate or maybe a little higher. This person they've only lost 0 to 15% of their blood volume. They're not in any great systemic danger here. They're not likely to die. Their respiratory rate is going to be matching their heart rate. Therefore, it's going to fall within normal range. They may, however, look pale because where they're getting their extra blood in this case is their skin. They're using that blood reservoir of their skin in order to bring their blood volume back, and they might look kind of pale. But otherwise, they're able to compensate with this. Once you lose, and I won't test you on the percentages here, but somewhere more than 15%, then you're tending to see your diastolic blood pressure go up because you're doing so much vasoconstriction that the blood vessels are tighter and their diastole is higher. Their heart rate and their respiratory rate are going to rise because you're going to have activated your sympathetic nervous system to do that vasoconstriction. So, of course, the heart rate's going to go up and your breathing rate is going to match it. You may not be getting as much blood to your brain. That may be causing this, but you're also activating your sympathetic nervous system, which means that psychologically you are in an emergency state. Again, you're white skin, but not only that, you don't have much blood going to your skin, so you are cold feeling on the outside. The clammy is because you're sweating, because if you go back to thermoregulation, it is a increase of sympathetic will cause you to start sweating. And you may find that you can't refill capillaries. That's what the perfusion test is. You're looking to see whether there's enough pressure for you to rapidly put blood into the capillaries, and you'll decrease your urine output. Okay, and then this case, you still could tend to recover as long as you didn't continue to lose blood. You can start to recover, but if it gets towards the higher end of this, then interventions might be necessary, like giving this person fluids to replace the lost volume and bring their preload back up to normal. Once you're getting into stage 3, you definitely need an intervention. Here, their systolic pressure is dropped below 100, and they have a fairly high heart rate. And you remember, once the heart rate gets high enough, then you start to lower venous return because you don't give the heart much diastole for the blood to fill it. They have a high respiratory rate. They probably are not getting sufficient blood to the brain, so they may act confused. They're usually profusely sweating, cold, and white, and they make low amounts of urine. So this person is in trouble, and you'll often see this in conditions, say, if they have heart failure, where you'll see people sweating, they're moving on towards having a heart attack, they're not getting enough cardiac output, or if they're, say, an accident victim, what you're trying to do is keep them warm so that, their skin isn't trying to do shivering or anything like that to raise their core temperature. They may be sweating. You want to raise their legs. But at this point, they probably need fluids to bring them back to normal, or a blood, give them whole blood. Once you're stage 4, your systolic drops below 70, this person is typically not able to survive this level of shock. So you can't maintain enough cardiac output. So do you have to memorize this table? No. The idea is to understand how some of these signs and symptoms relate to how the body's trying to compensate for the low blood pressure. Okay, so I put down some reasons that you might have high blood pressure. Some of these come up in the little handout, like age tending to be a loss of elasticity of the vessels. So take a look at these. I would know these on this side because they relate to the resistance concepts that we did in lecture. So things like obesity is greater length to the vessels, greater resistance. Diet, high salt, it has to do with water coming out of the tissues and into the blood. And then today in lab, he's going to do some orthostatic changes. Kevin is a young and healthy person, relatively young, so you're not going to see some big drops in his blood pressure, but you do see some changes with position. Now, he mistakenly calls these hydrostatic when he really means, it was a misspeaking. He meant orthostatic, a position change. Where you may notice it is that or you may notice it in a patient if you work with patients that have been bedridden. If you're bedridden for a while and go into so you're now in a reclining position all the time, gravity you don't have to work so hard against gravity. And so what happens even when you're sleeping at night is that your cardiac output will tend to drop. Your heart will not be beating as hard because it doesn't have to supply as high a pressure to get blood all over your body. Remember those baroreceptors in your carotid and aorta? Well, they'll reset if you stay that way, not so much with sleeping, but if you stay in bed like a hospitalized patient, that can reset to a lower level. So let's say normally your blood pressure when your normal activity is 120/80. If you become bedridden, it may drop because you're not doing as much, you don't need as much cardiac output, you don't have to fight gravity with your heart contractions. So your baroreceptors may reset to maybe 110/80. So you don't need to have as high a blood pressure. When that patient goes to sit up or walk, their baroreceptors are keeping them at a 110/80. They've reset, and that's not enough to get blood to your brain sufficiently, and they might get dizzy or faint. So that's one reason why when they discharge someone from the hospital, even though they might be able to perfectly well walk, they want to put them in a wheelchair and wheel them out so they don't accidentally faint or become dizzy because they've been in low low demand position by laying down for so long. And of course, then they dump you off in the parking lot and hope you don't fall there, I guess, but then that's on you. So here are some reasons for having low blood pressure that I mentioned. Anaphylaxis. Sepsis is when you have a systemic infection. So you're again getting a big inflammation response everywhere. Cardiogenic, hypovolemic. I think the book also mentions these. Okay, so we're done with this part. So I believe I still, if I stop sharing here, have our handout, and I'll just show you the new blood pressure assignment. So if you printed this out before Tuesday, you want to redo it because some of it's the same, but this is version 2. If you, oops, am I sharing the screen? Probably not. Am I? Nope, I'm not.
No.
Yep. Talking away here without sharing the screen. Okay. My reality is not your reality. Here you go. So make sure this is version 2 that you're looking at. I think the title on the top says, if I bring that down so I can see it, blood pressure assignment V2. It starts similar. I give you some answers to, tell me where these are so you have them as a nice summary of, if you've been taking notes, you can do it again. I give you a couple examples of murmurs to work with. And then I give you places to enter the data that Kevin is obtaining for you with his YouTube video. So this business of a radial apical ratio, that has to do with comparing what you can hear as a heart rate at the chest wall where you're listening directly to the heart to what you can feel out here when you take a radial pulse. So he must have gotten somebody to help him do this, but he did it for you. Now, why you'd want to do this test is explained in one of the little well, it's not an insert, it's actually a couple paragraphs, but it's a little bit buried. You have to go by the part in our lab book where they are using, they don't use Power Lab, they use another system to explain it. So make sure you read that part. But basically, something that interferes with cardiac function. So you have weak amount of weak systolic pressure, like atrial fibrillation would give you a weak systolic pressure because your venous, your end diastolic volume would drop, your preload would drop if you have atrial fibrillation, and therefore you might not be able to feel every one of the beats. It's not that they're not there, it's just that they're weak enough you can't pick them up with your fingers, and that would drop the apical, the radial pulse relative to the apical. So he comes up with a ratio of 1, which is totally normal, which thank goodness, I'm glad he's normal. But if it was anything less than 1 that's substantial, then you would worry about that person. So it asks you to give 3 reasons for it. Then you're going to record the data here, and there are a few questions that are embedded that you're going to answer. Not a lot of them, but there are a few, and I do read them. So make sure you understand what's happening. First of all, when it says flexed, it's a little hard to see, it doesn't demonstrate it. This is a totally flexed arm, if you remember from 103A. So extension is when your arm is straight down, flexion is when your arm is straight up. So he's going to hold it up there for a while, and you're going to see what happens to his systolic pressure when gravity is now acting on it. He also does from seated to immediately standing. Again, that's an orthostatic change. And what happens immediately to his blood pressure, and then how it compensates 5 minutes later. So make sure you understand these, and I'll turn you loose to go about and do his video. And if you have problems, you can let me know. So you have, I think, about a half hour left to do this. And I do encourage you to do the mastering one as well, where they look at that using the Doppler to look at the ankle versus the brachial artery and get the ABI from that. Okay, so lots to do, so I'm going to stop talking and just shout out, I'll be here. Sometimes I change screens, but I'm here if you're having any difficulty. Would anybody like to be in a breakout room? I will do that at any point. I'll check chat, or I'll try and check chat as often as I can. So if there's anyone who wants that now, I can set up a breakout room and you can work together. All right, I'll let you go, and just let me know what's going on if you need any help. You want to go out, Pooch? Let me get rid of my